Okay, I think we'll get going, guys. So, good evening, everybody. I'm David Dean. I'm the Chief Officer of Community Pharmacy Thames Valley, and I'm delighted to welcome you to another Community Pharmacy Thames Valley Academy webinar evening. This is the second one in a series of many webinars we'll be running over the coming months. And I'm delighted to welcome Clare Holland, who will be presenting mainly tonight, Ian Dunphy, who is our chair, and Kevin Barnes, who is our contractor support officer. And I also noticed we have a couple of friends of the LPC on as well, so welcome. And we also have a couple of committee members as well. So there'll be plenty of time to ask questions. If you want to put something in the chat, then please do so. But hopefully I have a few minutes at the end for you to have a bit of a Q&A. So I'm just going to pass over now to Ian to start the evening off.
Good evening, everybody. Thank you very much for attending. And hopefully this is going to be the start of many more Academy presentations. I'm going to hand you over very shortly to Clare Holland, who's going to be leading our Academy. She's a GP practice pharmacist with a long history in community pharmacy, and she stretches back with her relationship with the LPC all the way back to 2014. So thank you very much, Clare, for hosting another what will hopefully be a really informative presentation on the Hypertension Case-Finding Service.
Thanks, Ian. Thank you very much. So hello, everyone, and welcome. I'm absolutely thrilled to be joining you again this evening. Thanks to the LPC and the Academy for having me back. As Ian said, I'm Claire. I'm currently a GP practice pharmacist in Buckinghamshire. And tonight we're going to be delving into one of the most powerful and accessible pharmacy-led services, the Hypertension Case-Finding Service. So I'm really hoping by the end of the webinar, you'll be up to speed on the updated service specification, armed with some practical strategies for delivery, and walk away with some actionable tips to strengthen collaboration with our GPs or other partners in this area. And we'll also explore some tools and tips that you can use to train your team and scale the impact of this service. So while everyone is still joining, let's get started. Before we get into it, let's just go over some ground rules. As David said, please do mute your microphone. It really does cut down on any background noise. And if you can, keep your camera on. It's really nice for engagement if we can see everyone as a group. I really would encourage you to maybe open the chat function now if you haven't already. As David said, it's great. We want to encourage some participation. And you never know, some of the information and advice you put down in the chat box might inspire other people or others in the room to think and take away some of those tips as well. If you do have any issues, use the raise your hand to speak, and David or Kevin will be able to help hopefully with any technical issues. And just to say as well, if you are using the chat function, obviously make sure comments are constructive, maintain confidentiality at all times, and try and stay on topic. So hopefully we've got everyone joined now and we're ready to get started for real. So what does hypertension mean or call to mind when you think about it? And I'm sure lots of these words are all too familiar to us in practice. And this visual really represents the heartbeat of hypertension care. So we've got practical tools in there like ambulatory monitoring, and we've got service specification, a patient facing ideas like lifestyle support, diet and stress. And tonight, let's try and bring the words beyond theory. So what can we do tomorrow to make hypertension screening more visible, more impactful, and ultimately drive positive patient outcomes? So David, if you really kindly launch a poll for us, I've also tried to put it there as the QR code, but hopefully David will be able to come in. There we go. So It's just a really simple question, and it really is just to gauge what your confidence levels are in delivering the service so far. And that can be not confident, do not worry, do not be shy. You might be getting there, and that's fine. And if you are very confident, thank you very much. We're going to be relying on you for your hints and tips as we go through the webinar. So please do share them. I'll give you a moment to do that. I feel like we should have some musical interlude or something like Under Pressure or some music like that to go in the background. And if you've done that, are we getting some results in, David? Are we getting any numbers through?
Yes, we are indeed. Shall I end the poll now so you can see the results?
Yeah, that would be great. Yeah.
So hopefully you can see the results.
Yeah, so that's really positive, isn't it? That lots of us, almost a third are very confident, which is super. And as I said, sharing your information and advice in terms of hints and tips for colleagues will be really helpful, especially those who maybe feel that they're not quite confident yet, or they're getting there. So it might be just those little nuggets of information that they're missing, to get the best from the service. While we are looking at while we're going through the slides, it would also be really helpful if you would share with us in the chat some of your biggest barriers, so we can see what the common themes are, and what's really blocking the delivery of the service. Most colleagues that I've spoken to have highlighted two key areas, engagement with the ambulatory blood pressure monitoring being one, and the other one being GP collaboration. So hopefully we'll be able to look at those, or that we'll go through those through the webinar. But if there's other things in there, then we might, as David said, have time at the end just to look at those in more detail. Okay, so let's go on then to what is hypertension. So hopefully, again, this visual is really recognisable to lots of people. It's the visual guide from NICE Guidance NG136. And hypertension is defined as persistently elevated blood pressure. And what that means in practice is that in clinic readings, that's above 140 over 90, or average home or ambulatory readings of greater than 135 over 85 for those individuals who are aged 18 to 80. When we look at patients who are over 80, the threshold moves a little bit. So clinic readings, we want those to be less than 150 over 90. And then at home, those patients, we want their average blood pressures or ambulatory readings to be less than 145 over 85. And the reason that these targets are different, and you might get asked this question, is that we're trying to balance the cardiovascular risk reduction with safety. So particularly considering that older adults can be a greater risk of postural hypertension, and also greater risk of frailty too. So that's where we get that slight difference. CPPE training requirements highlight that staff are expected to understand relevant sections of NG136 that apply to their role with the service, and be familiar with the service specification. And it should also complete training on the blood pressure equipment that they're using, which is often with the ambulatories provided by the manufacturer or supplier. Hypertension or blood pressure is really common, as we'll see, and 30% of adults in England have the condition. Many of them are undiagnosed, and there was lots of missed opportunities in the pandemic years. And unfortunately, it silently increases the risk of heart disease, chronic kidney disease, and stroke. And it often develops over many years and can go unnoticed without these regular sort of screening checks. Managing hypertension involves lifestyle changes, so the usual things like healthy eating, exercise, embracing that, and if needed, moving on to prescribed medication. And community pharmacy, once again, has been at the forefront of supporting the NHS long-term plan in helping to identify and support patients with this condition. And how have we done that? So The Hypertension Case-Finding Service has existed since October 2021. And it's got two aims really. Well, the main aim is obviously to find patients with undiagnosed high blood pressure, and it's got two parts. So we've got the initial clinic check, which is offered to adults typically over 40. But if indicated, ambulatory blood pressure monitoring can then be offered. The clinic reading helps to identify the patients at risk. So those with elevated readings of greater than 100 and greater than or equal to 140 over 90, but less than 180 over 120, can then be offered ambulatory monitoring, which involves wearing a device that records their blood pressure over a set number of hours. And the ambulatory monitoring provides more accurate diagnostic data and supports onward referrals to that patient's GP for assessment and management. Pharmacies, as Kevin will cover a bit later, must be equipped to offer both components of the service. And from October this year, it will be a requirement to deliver one ambulatory consultation per month. Kevin will highlight a little bit later on what the current state of play is like across the region. But this proactive approach in engaging with this service and completing both aspects of it helps early identification, and it supports better health outcomes, and ultimately it reduces the risks associated with untreated hypertension. So if we look now at what those risks are, the NHS has identified high blood pressure as one of three key risk factors in an umbrella for cardiovascular disease. And they're ABCs. So we've got atrial fibrillation, irregular heartbeats, blood pressure, and cholesterol. Hypertension is all too common, as we already said. Roughly 4.2 million adults in England had undiagnosed hypertension between 2015 and 2019. And it tends to be younger adults and those perceived to be in good health who are more likely to go undiagnosed. And in England, cardiovascular disease is responsible for 1 in 4 deaths, and many of those could be prevented with early detection and intervention. And hypertension, particularly, is most concerning because it's the leading cause of premature mortality in deprived communities where maybe access to care isn't as good, or there's a lack of awareness. So this isn't just about numbers, it's about missed opportunities. So every time we identify and support someone with high blood pressure, this could be through even our NMS services, we're giving them a chance to live well for longer. So we're reducing the risk of major conditions, major cardiovascular conditions like heart attack, like stroke, like heart failure. And through these types of initiatives, we're actively closing the gap that widened significantly during the pandemic years. So it really does matter, and the impact of getting the service right is profound. So let's move on to unpacking the updates. And I'm hoping none of them sound as scary as or look as scary as they sound. And what we really want to do is show that actually they're trying to make things more achievable. So the major headline, which we've talked about already, is the condition on payment now that to qualify, pharmacies must deliver at least one ambulatory consultation per month. And the monthly minimum is there to encourage consistent service integration, so streamlining hypertension identification and supporting diagnosis, ultimately, as we said, to better patient outcomes. So we need to start thinking now about ambulatory monitoring and change our mindset as less of an optional extra to essential part of the pathway. So, and we'll get a bit more from Kevin on that in a little bit. We already know pharmacists are not flying solo. Trained team members can now deliver much of the service under the supervision of pharmacists and technicians. And this really opens up the workflow flexibility and helps upscale the service. And it means that we can recognise the skills in our teams and allow a more hands-on deck approach with less pressure on pharmacists and technicians and shorter wait times for patients. So that's really important too. The next one doesn't sound great, but the updated fee structure, which has kicked in already from the 31st of March, in which the clinic fee dipped. But ambulatory has been boosted, and this really is important because it reflects how much of it is a key part of the hypertension case finding workflow. It's the gold standard in monitoring, and it's what NICE says we should be using for hypertensive patients. So if you've been ambulatory monitoring shy, now is definitely the time to get involved. And another selling point around the ambulatory and making it a bit easier and more convenient is we're less hung up on the strict 20. Oh, I think you might need to just mute there. Thank you. Making it a bit easier for us practically delivering the service, but also for patients. So it's now okay for the patient just to wear the monitor in waking hours. And this added flexibility not only supports diagnosis, but it actually doesn't compromise clinical standards. So it's seen as just as good, the data is just as good and robust. And the final update, and I'm going to ask Ian to come in a second on this, but we have got clearer eligibility criteria in relation to groups of patients that general practice are able to refer to the service. So patients now under 40 can be included only if referred by a GP. And we will look at the surgery pharmacy relationships in a little bit later. But Ian, did you want to come in here and elaborate on that eligibility at the moment?
So yeah, the eligibility is a grey area when you read the service spec. If a patient has a referral from GP, pretty much any patient will qualify, even if they're unusual. What the service spec is trying to get away from is a patient who needs regular blood pressure monitoring, which is not case finding. So they've already got the condition and they need day after day monitoring for over a week or 2 week period. But even patients under 40 and pregnant ladies or anybody who the GP thinks requires some sort of blood pressure monitoring on a non-regular basis can be signposted to you. The best thing to do is either use your professional judgment as to how to qualify a patient, or get a written referral from a GP, and then you are covered. You won't have a problem. The ideal would be to get a letter from your GP practice stating that they are happy for you to take blood pressure readings from a certain criteria or certain qualifying set of patients. And that will simplify everything. And then you will not have a problem with the NHS BSA looking through your figures and going, oh, that one doesn't qualify, so we're going to take that payment back. Does that help?
Yeah, thanks, Ian. That's great.
Okay.
And we'll look at how we can collaborate with our GP partners in a little bit. So let's walk through a real world consultation for the hypertension service. Hopefully you recognise these screenshots as they're directly from Pharma Outcomes. And the goal is, with all consultations, with all our patients, it's all about making it patient-centred from start to finish. So it begins with a warm welcome. We're not just checking blood pressure. We're building rapport here. We're helping patients feel at ease, and we're clearly trying to communicate the value of the service. And once the patient's on board, then we can look to confirm their eligibility and gain consent. And again, here, it's just about keeping things simple, clear, and professional before we move on to gathering some key information. And it's here that we can really dig into a little deeper and look at things like family history, look at lifestyle factors and subtle symptoms. And that can all be really helpful when we're going to tailor advice to our patient, and also help us in spotting potential red flags. And we've got more on the red flags in a little bit. When we conduct the blood pressure check, getting this right is essential, and we can use resources like the British and Irish Hypertension Society to help with ideas on how to do it. But essentially, things you need: a validated monitor, make sure that patient is comfortable, they've got their back supported, their 2 feet flat on the floor, their arms resting at heart level. And ideally, they've avoided caffeine, they haven't smoked before they've come in, or exercised within the 30 minutes beforehand. And providing 5 minutes of rest or calm is really helpful for everyone, for all patients before they're having their blood pressure taken. So you can direct them maybe into the consultation room while you're getting things ready. And again, it just allows the patient to feel settled and a bit calmer when we're doing the readings. We're taking 2 readings spaced 1 or 2 minutes apart. If they vary significantly, then we can do a 3rd reading. And it's really important not to rush these steps, and not to be talking when you're doing it, and explain that to the patient as well, because they might find that a bit strange that you've been talking and suddenly stop. But it's about accuracy and building trust. So we're recording the average of the last 2 readings just to stay consistent. And these aren't just clinical steps, they're vital for patient engagement and to demonstrate our commitment in community pharmacy to quality. When we have the results, we need to interpret them with the patient about shared decision making. So for normal readings, still as part of NG 136, we offer lifestyle advice and reassurance, and that lifestyle advice is useful for all cardiovascular disease prevention, and we'll go over those in a little bit. If the readings are high, this is an opportunity for us to explain ambulatory blood pressure monitoring and why it offers greater precision and how it works. And again, we've got a bit on that in a little bit. If the readings are really high though, and they're greater than 180 over 120, and we may or may not have symptoms, but those patients need to be swiftly referred, and that's not to the GP, that's A&E or the rapid access chest clinics. So we talked about small tweaks and allowing the patient to have a little sit down, but all of those can have massive ripple effects. So proactively rechecking borderline results to catch issues early can build patient trust. It shows that you are about quality and shows the patient that you care about precision. And also when you're doing it, as we said, following up if you have got a high reading, a higher clinic reading, and ambulatory monitoring is suitable, doing that promptly ensures timely intervention between the clinic reading and fitting the ABPM. Because this is where, when we get the ABPM results back, momentum can really build for the patient. And if we delay this, we can risk confusion, we can risk misdiagnosis. So prompt reporting really does mean prompt care. And the language we use is really important. So quick blood pressure check can really change how a patient feels about what they're engaging in. And we can look at some scenarios in a bit about how we might talk, what language we might use when we talk to patients. And don't underestimate the power of visuals. So patient-friendly leaflets and visual prompts, like this poster has just come from Community Pharmacy England, and I've cut it and put it in here. But it's memorable and it's clear, and it supports patients with their understanding and again going on and explaining shared care and involving them in their decisions about what they want to do next. So if we can, and we are fitting an ambulatory monitor, and it is required. Ideally, it would be great if we could just do it there and then. But in reality, it's more likely that that machine is booked to go out late morning and return the next day early, with some time then to get it sanitized and ready for the next patient. Some pharmacies I find it really useful to have loan forms when they are fitting these devices. And again, that's just to ensure, asking the patient to sign it, to ensure safe handling and return of the device. So that might be something as an added tip that you might want to add to your practice. And those of you who are really confident in doing it might already be doing that. And have templates for doing that you might want to share with others. When we're fitting, we need to give the patient some simple instructions about ambulatory monitoring. So we might say things like ambulatory monitoring is a way for us to get a clearer picture of your blood pressure through the day, not just a one-off reading in pharmacy. We'll fit you with a small monitor that will check your blood pressure every 30 minutes when you go about your normal routine. It's painless, so again, it's important to let the patient know. It's pretty discreet, and you can even sleep with it. And the reason we want to fit it is it helps us spot patterns. So to see if your blood pressure rises at certain times of the day, or if it's only high when you're in clinic, and this is something we call the white coat effect. And then underline again to the patient that the results give your GP a much better idea of whether treatment might be needed. We're going to show the patient how they're going to wear it and arrange that follow-up again so that they know to bring it back, and go through and explain you will go through the results with the patient together. Again, it's an opportunity to underline to the patient this is the gold standard for diagnosing high blood pressure. And the reason we want to do that is to prevent, again, serious heart conditions or problems down the line. And this reinforces the value of the service, and the schedule fitting is important so that we don't end up with any dropouts. So what happens when the patient brings their device back and we're ready to do the follow-up? So again, keeping it patient-centred. I've included a really simplified spliced-down version of the Pharma Outcomes template. But keeping it patient-centred, we're going to give them a nice warm welcome. And we're going to check how they got on with using it. So ask them if there's any issues. Was it uncomfortable? Did anything happen in the day? It shows that you care, but also it builds a bit of context in as well for the data to see what might have happened in the day that might have caused spikes or triggers. And then when we're looking at the report, so we're looking at the average, highlight patterns like persistent elevations or spikes. But it's not just about the numbers, it's spotting trends that can point to real risks that need to be investigated. And when sharing the results, it's best to keep that as simple as possible. So we might say your average blood pressure across the day was 138/86. And I might give them some context about what the target might be according to NICE, and that we're looking for that to be less than 135/85. We want to reassure them that it's slightly high, and that it would be worth discussing this with your GP. But it's so helpful if you can manage the patient's expectations around this as well. And again, this is something, if you've already got that GP collaboration link going, then you will know what the process is likely to be when you've handed that information over to the GP. Because remember, saying your blood pressure is slightly elevated might make that patient feel quite anxious. And up until 24 hours ago or 5 minutes ago, they didn't know they had high blood pressure, and they were walking around perfectly happily, and suddenly now we've caused alarm. So we just want to manage that expectation, and again, that's important to have that link in with the surgery and to know what timescale it's likely to be that they're going to get seen and followed up. And in the surgery, it's likely when we're looking at diagnosing hypertension, they do a set of cardiac bloods, and they probably will end up having an ECG. But again, confirm that with your local practice as just that stretch and added bit of care. Ideally, if their blood pressure is normal, and still offer lifestyle advice. So still look at salt intake and look at exercise. And we've got some slides on that in a little bit. If it's raised, obviously, we're sending the information straight to the GP. If it's very high and they're experiencing symptoms or without symptoms, that's going to be a same-day referral. But as I said, that is going to the A&E or chest clinic, and we'll cover the red flags in a moment. This is all an opportunity, though, to engage with the patient. So in this consultation and the ABPM follow-up, it's about small changes in daily habits that can make big impacts. So signposting them to NHS leaflets, if you've got those, or have websites like the British Heart Foundation tabbed on your desktop. Making it personal, making it practical, and we can look at those in the slides in a little bit with apps and QR codes that you can use to direct the patient. And finally, Kevin's favourite bit, making sure that all the consultations are documented. So make sure Pharma Outcomes documentation is done and sent securely to the GP. The follow-up bit, the ABPM follow-up, is a golden opportunity, not just to refer or reassure, but empowers the patient. So every really well explained consultation strengthens our role as healthcare professionals, and we want patients to be able to recognise hypertension, especially as it's linked to such devastating cardiovascular consequences. So the red flags, here are some of the cardiovascular red flags that I would go through with patients if I'm talking to them about blood pressure, or I'm talking to them about cholesterol, and they're just this sort of CVD symptoms that we should never ignore. And they include severe headache, which might indicate that the pressure in the brain is going too high. Blurred vision or visual loss can be a sign of vascular damage or retinal complications. confusion, that might point to, or seizures, obviously, that's neurological involvement, and that should be treated urgently. Chest pain or tightness, and we might start to wonder if angina is coming into play here, or things, we're leading up to a heart attack. Shortness of breath. So normally that's associated or quite heavily associated with respiratory conditions, but in heart failure, unfortunately, it can be a really debilitating symptom that patients can deal with, and so can be a real sign that the heart is in distress. And if a patient's reporting palpitations, or you've picked up an irregular heartbeat, that might suggest an arrhythmia, which is also putting strain and could be causing some damage to the heart. So again, these are all red flags and need to be referred either to general practice, although if we've got a serious situation where they're particularly problematic for the patient, then you might want to consider A&E or the chest clinic. And obviously, as we said earlier, blood pressure is greater than 100, so systolic is greater than 180, or diastolic is greater than 120, or for prompt referral to A&E or the chest rapid access clinics. So we talked a lot about lifestyle and the importance of it generally for cardiovascular disease. And our role doesn't just stop at finding these patients and sending them off to general practice or for a diagnosis. Beyond the numbers, we've got the power to be able to influence behaviours, and we're perfectly placed to make meaningful lifestyle changes. So let's start with diet. Can anyone pop in the chat what the daily salt allowance is? Is anyone... You want to let me know if anybody's popped that in? Try not to look at the chat because I get distracted. Have you got a number?
Yeah, 6 grams seems to be
six. Yeah, brilliant. Super. Excellent. That's what we were looking for. So 6 grams is right. So we want to encourage patients to try and avoid processed foods if they're consuming a lot of those, and opting for fruit and vegetables and building in some fibre. That can all have a big impact. And encourage patients to check labels, and there's a label checker app as well that we can look at in a moment. Flag that alcohol and caffeine in moderation can actually have significant impacts on cardiovascular health, maybe not necessarily directly on hypertension. This is very small, and you can put in the fact sheet we'll put together, it'll be much clearer, but this is from Medscape, and they have included how much difference these changes can make. So say, for example, salt, that's the impact of reducing salt can take about 5 millimeters of mercury off a systolic reading alone. And that can be really important for patients and make the difference between needing to either start medication or run the risk of a cardiovascular event in the future. And it's probably really key for those borderline patients, or those patients that maybe need a step up in treatment as well. So physical activity, so movement as medicine is a bit of a buzzword at the moment. And again, anybody remind, or anyone know, if you want to pop in the chat box for me, what the NHS recommendation is for moderate activity weekly, or intense activity. If we get any numbers through, David, just shout.
Yeah, waiting. 150 minutes a week.
Yeah, super. So that's bouncing in now.
Everyone was 150, right.
Yeah, 150 minutes of moderate activity, or 75 minutes of vigorous activity per week. And that can be little things. That can be walking, swimming, dancing, whatever works for them. I had the most fantastic conversation with an 85-year-old lady this week. And she's recovering from a fall, and she cannot wait to get back to her weekly Zumba class, which she thoroughly enjoyed. It sounds like torture to me, but that is what she wanted to do. So it's about consistency. It's not necessarily intensity, although we do need it to be either intense or at 75 minutes or 150 minutes of moderate activity. But patients can start small, and they can build it, and they can build it up. And one of the most common or recognizable ways to embrace exercise is the Couch to 5K. And again, it's probably really difficult to see on the screen here, but Physical activity can take a whopping 7.5 millimeters of mercury off a systolic and 4.5 off a diastolic on average for patients. So again, if you've got someone teetering on the edge and not sure, this is something to encourage them. And I would have this either tabbed or printed out in the consultation room, or tabbed on the desktop computer. Weight management can be really tricky to approach, and it's really important that we keep it sensitive and we're supportive. And there are tools like the BMI, the NHS and BMI calculator, and we can use waist circumferences and things like that. But again, in terms of impact, for adults, so overweight adults or obese adults, every 5 kilograms that they lose can reduce the systolic, sorry, by 4 millimeters of mercury, and diastolic by 3. So not unsubstantial in terms of impact there. And the lifestyle doesn't stop there. So smoking cessation, if you've got a smoker, you can offer smoking cessation support. And that might be selling something over the counter or signposting them to local services. It is one of the most powerful interventions for heart health. Where I am in Buckinghamshire, we use Be Healthy Bucks, but check what your local referral scheme is, and maybe make some links in with them. The other one that we talked about a bit at the start with young adults and things like that is stress and sleep. So sometimes that can be overlooked. And it's, again, if you're able to share some ideas around screen-free time, mindfulness, good sleep hygiene, it can sort of help empower patients to take control of these areas. And we've got more ideas on doing that. So this is this on the side is from the NHS Better Health website, and it's a really vibrant hub. And I would again just encourage you to have it tabbed on your desktop. It's designed to help patients or people make small, sustainable changes that lead to long-term better well-being. It's particularly there for lifestyle interventions that complement services like the Hypertension Case-Finder, like NMS, things like that. It's got weight loss advice, so it directs patients to a 12-week structured program that's NHS approved. It's got advice there about quit smoking. It's got advice about reducing alcohol, and of course the famous couch to 5K. So it is really worth having that available and directing patients to that. And again, it's nice and discreet, and they can just scan codes and things. Lifestyle change often just begins with awareness. So this Better Health website gives patients information, but also tools to be able to act. And that's where we come in. Do not underestimate the power of brief intervention, especially delivered in healthcare settings like pharmacy. It can have measurable and cost-effective impact on patients' behaviour and long-term health. Very brief intervention advice, so even 30 seconds long, can triple success rates when paired with support, according to one of the government websites about smoking cessation. So even if it seems like a small comment, it might have a massive impact on that patient. So what consultation techniques can we use? It's all about maximising mini moments of care and building trust and uncovering risks. So has anyone struggled with patients getting them on board for blood pressure checks? Again, if you want to pop how you do it in the chat box, that might be helpful and helpful for others to learn from. I know when I spoke to my local community pharmacist, they had a HCA who everyone particularly wanted to have their blood pressure checked by. And so it's about using the skills that you have in your team. But if we look, say, for example, an older adult, when we're not a younger adult, where we're maybe not sure what age they might be, something we could say is, hi, while you're here, we're doing quick blood pressure checks for anyone in and around the age of 40 or even younger people like yourself, because high blood pressure can sneak up and it can do that without symptoms, and it's all about prevention. And sometimes we see higher readings in people who are juggling stress, caffeine, sleepless nights. It's nothing to worry about, and it's just a 2-minute check to be sure. And this scenario tackles the assumption that young adults are off the radar for hypertension, and it reframes the conversation around blood pressure checks being lifestyle relevant and touches on things like stress and sleep, which is relatable for a lot of younger patients who maybe have, children not sleeping through the night and things like that. And the tone's light, so it's not causing alarm, it's just trying to gain engagement. And if we look at referrals from general practice, in this scenario, we can say things like, I see your GP suggested a blood pressure check. We're happy to do that here. If anything needs follow up, we'll pass that information to your GP. So it's making comments like your GP suggested, which builds continuity and trust. And we add transparency there by saying if there's anything that needs to be followed up, and we can explain that link with the GP clearly, and explain that this information goes straight into their medical records, which again is really important then for that kind of joined up healthcare. What if we have an elevated blood pressure? So we need to shift towards a reassuring, no need to panic. And this is really important as well if we're trying to then get the patient to engage in ambulatory monitoring, and see it less as a clinical burden, and frame it more as a way of the patient being able to avoid unnecessary treatment. So the narrative shifts from being problem focused of, oh, we've done a clinic reading, your blood pressure is high, and to solution focused, we're acknowledging that your blood pressure is high, but we're going to do something about it, and we're sort of gently nudging the patient towards trialing the device. And again, for all the reasons we've explored already about why ambulatory is gold standard, and it's what the NICE guidance tell us we should use. So again, I'm not sure if anyone has popped any tips in there, but if there's anything, any ways or phrases that you use to speak to patients, it'd be great if you could pop those in the chat and we can collect them all at the end. And then we look at collaboration tips. So it can be really difficult for GPs and pharmacy collaboration. It can feel a little bit like a maid rather than a motorway. Again, please share in the chat if you've got anything that's worked well and that you're happy to share that you have done with your GP practice that's made this service work really well. Some advice that I've had or I've seen from community pharmacies that have interacted with us include that really strategic relationship building. So go and seek out your PCN or practice-based pharmacists or practice managers if you can, and set up regular meetings. Not always achievable, but start with trying to do that. It's all about presenting your service as a solution to GP pressures. So align with their clinical, their operational, contractual goals like QoF and CVD prevent. And things like improving patient outcomes, reducing appointment backlogs. These are all really key buzz areas in general practice, and they love to hear this. The key angles that resonate strongly with GP practice include QoF. So hypertension specifically plays a huge role in QoF this year, and it rewards practices for blood pressure control in hypertensive patients. So we're not just checking blood pressure in community pharmacy, we're helping practices achieve their targets, which for them translates directly into funding. Another area to underline is clinical confidence. So reinforce that the guidelines we work to are the same. So we're all using NG136, and actually the ambulatory pathway offers more robust, detailed clinical data directly to their clinical system, which they can then act on. This also helps with workload relief. So again, you can underline that you're lightening their load. Routine blood pressure checks can shift to pharmacy, and that frees up HCA time in the practice as well. And also another key area that sometimes gets forgotten about patient access. So in community pharmacy, we reach patients that don't attend the surgeries, especially those who maybe are working or they've got accessibility barriers. So we're finding those undiagnosed patients that maybe have never come into contact with general practice. And then once we've established those relationships, it's really, really important that we send the ABPM data promptly via Pharm Outcomes. And if we can collect patient symptoms and follow-up needs for context, and also help to manage the patient expectations too, because this helps foster a bit of trust and maintains consistency, and also it involves sharing clinically really valuable information. establishing those direct communication channels is really important. So get the email addresses, make sure they're NHS email addresses as well, but make sure they're manned too. Direct lines to streamline patient queries and referrals, and remember those patients with really high blood pressures that are going straight to A&E rather than the GP surgery. And the clearer the information on processes is, the less opportunity there is for confusion. So don't wait necessarily for those systems to align perfectly. Get your own channels going. Maybe the odd phone call. The faster the loop, the stronger that partnership will be. And troubleshoot. So identify scenarios that we talked about earlier where perhaps maybe the average readings are high, and have an idea from your surgery what that patient's journey and next steps are going to look like and what timescale to anticipate. That's really important for the partnership to work well and minimize friction points. We've all had patients walk straight out of our pharmacies and go straight to reception and say, the pharmacist says I need an appointment today. And that completely undermines us and undermines the service and what we're about. So work to try and identify those. Is there a referral template that you could provide the patient with that states what you said? And it also obviously means the patient is aware too. When you get it right. So if your patient journey has started off with you doing a quick blood pressure check and ended with a diagnosis and a treatment, and now you're about to call them to do an NMS call, share that with the team, because it's probably been one of your healthcare assistants that's done the blood pressure check in the first place. So celebrate that success, but also remember the ultimate goal here is CVD prevention. So we're helping patients not only achieve positive outcomes, but live long and healthy lives. And in terms of practical delivery and working with general practice, coordinate public health campaigns. So have a look. Things like Know Your Numbers Week can really boost public engagement with blood pressure checks. So see if you can display posters in the surgery. This shared messaging also helps build patient trust. So it shows we're not working in silos, but we're actually part of a united healthcare system. And that's really, really important. So just in summary then, the key takeaways. So first of all, this service zeroes in on one of the most powerful predictors of cardiovascular disease, hypertension. Because it's so tightly defined, it's much easier to slot into our already existing workflows without overwhelming the team, because we can use the whole scale of the team. Secondly, in pharmacy, we're using the gold standard. So we're using the NICE approved ambulatory blood pressure monitoring. And that gives solid clinical credibility to not only GPs, but patients as well. It's skill mix friendly, like we said, so we can empower and train our non-registered staff to be able to deliver the service under supervision. And that means that pharmacists and technicians are able to delegate this confidently and focus on maybe the more complex tasks or services. And that improves overall efficiency for everyone, and including the patients. And finally, let's not underestimate the public health impact. Early detection of hypertension can literally save lives. It can prevent strokes, it can prevent heart attacks, it can prevent diseases like chronic kidney disease. So every check that you're delivering could be a life-changing moment for someone, and that cannot be underestimated. So here's your hypertension call to action. What's one change in your practice that you want to make tomorrow? Is it going to be train a member of staff? Are you going to update your SOPs? How are you going to boost your ambulatory uptake? And again, it'd be great if you could share those in the chat, and we can put that as part of the resources. And I would just like to say thank you for your time this evening. Really appreciate the energy, particularly anyone that replied in the chat. Feel free to send us some feedback. The email addresses are included at the end of the session. But I'm going to hand over to Kevin now, who will talk through the current pharmacy service delivery with a focus on hypertension. So over to you, Kevin.
Thank you very much, and good evening, everyone. The ABPM, hypertension, ABPM especially, is going to become very important in the next couple of months. And you've all heard about pharmacy first bundling. Next slide, please, Claire. Pharmacy first bundling came into effect from the 1st of June of this year. and you need to register for all three services. That's Pharmacy First, Hypertension Case-Finding, and PCS. And there's the thresholds below in terms of the payments. Next slide, please, Claire. What is important is you do need to have done an ABPM ABPM test to qualify for a Pharmacy First thresholds. On this slide here, you can see the number of sign-ups of pharmacies eligible to do Pharmacy First. So it's 99.4% of all the pharmacies in the LPC area, which is great. 97 have signed up for hypertension. 91 have signed up for PCS. But it's about 90% qualify for the bundling. They need to have signed up for all three and eligible to do those. And remember, we only have 1 month to claim your when you've done your tests. As Claire said, please every month make sure you submit your claims in MyS. I spoke to a pharmacy manager today who is one of the highest in ABPM tests, and they forgot to submit. Their team member forgot to submit in May. Yes, he's aware of it, so it will go through in June, so they won't lose it. They were not aware of it. They may have lost that payment and the Pharmacy First threshold. Next slide, please, Claire. So as I say, be prepared. And Claire's gone through that in her slides, liaising with the surgeries, trained staff, etc. Because as in October, you need to have done 1 ABPM consultation. ABPM is important, but in October, we also have the flu season kicking off. But we also do, the last year, we did 30% increase in hypertension tests, BP tests, to September last year and December, 30% increase. There's enough opportunities to have ABPMs done. However, don't wait till October, because that'll be the first time. Start now, getting staff trained, being aware of what's going on, so that we can start to deliver an ABPM in July, August, September, and ramping it up ready for October, because that'll be an important financial month for you. And we also then believe, come March, there will, under the PCS consultations, we believe, an oral emergency contraception. So one initiation needs to be done. So again, start getting your staff trained on PCS. Get aware of what needs to be done. These two services, it's about driving pharmacies into delivering services and to make sure we are making it financially viable. ABPM has increased to £55 now for payment, and blood pressure has decreased £10 to fund the ABPM test. So let's start maximizing the financial benefits, not only to the pharmacy, but to the patient, more importantly. Next slide, please, Claire. This slide just shows you since December to May, so it's 6 months, we have 120 pharmacies across Thames Valley, LPC area, that have not done 1 ABPM in 6 months. We have 1 to 5. We have about 25 pharmacies that have done a couple, but in random. So then they wouldn't have qualified over the 6 months of if it had been now in terms of ABPM with payments. And then we have just under 60 now, 69 pharmacies have done 10 or more. Some doing 25, 30 in the month. So the top 2 levels, the above 6, they can continue and grow. They've already broken that threshold. But there's a lot of pharmacies below 6 and below that need to make sure ABPM is a way of life, the way we need to be doing it. Because in theory, we have 320 pharmacies that could be doing an ABPM. So ideally, we need to have at least 320 in October. That's a massive step change. Let's start thinking about it now as opposed to waiting to October, and then it's a big panic because of flu, etc. So let's start doing that now. As Claire said in the slide, get the staff trained. Someone mentioned on the chat now about they sent an email to the practice and they've had some fantastic results. Email, speak to the practice manager, the practice pharmacist, make sure that they're aware of what we can do and support them. Next slide, please, Claire. So how can we improve? So say, speak to the practice. Let's agree a pathway between the two practices. What do they want? And how can we support them as well? Train your staff to do, not only to do a BP test, but also understand what an ABPM entails. That is important as well. They can reassure the patient during the BP test. Offer this ABPM to every eligible patient. Just make sure it's the numbers in terms of getting out there. Don't just wait, offer it, talk to people, start preparing now, as I said. Don't wait until October. I spoke to a new pharmacy owner. He took over a pharmacy a couple of months ago who had never done a BP test. And he's already done over 200 in the last 2 months. And he's had 12 ABPMs done already this month of July and 10 already booked. He's just purchased a second ABPM machine, all within 2 months. Brand new pharmacy manager, or owner as well. So it can be done. He's come in, he's just opened up, brought in new ideas, didn't listen to the staff and it doesn't work. He's opened up his mind and looked at opportunities. Next slide, please, Claire. So please, you've got our email addresses there. Please, anyone, any ideas, want some support, discuss with myself, please, you're welcome to drop me an email, Kevin Barnes or Kevin at CSO, or you can give me a ring. So that's my numbers on the LPC webpage. But thank you very much. Any questions, please reach out. David, over to you.
Yeah, thank you, Kevin. And thank you very much, Claire, once again, and to Ian, of course. And I just want to, just to make sure that you're all aware, and you won't be yet because we haven't told you, that we are going to be running 2 face-to-face evenings, one in September in Oxfordshire and one in October in Reading, around the new emergency contraception service, which launches in October, IT prevailing. So look out for dates for that. We're also going to have a couple more webinars before the end of the year, one on NMS, and then a combined pharmacy contraception service and emergency contraception service training module for you as well in December. And we're very excited to announce that on November the 2nd, on a Sunday, we're going to hold a women's health event at the Holiday Inn in High Wycombe, where we're going to have a day of speakers talking to you about HRT, menopause, UTI, sexual health. We're going to have CPP there, hopefully representatives from sexual health clinics around the Thames Valley area. And Claire, myself, Kevin and Ian will be there, and other committee members to run some small sessions around ways in which you can maximise services within your pharmacy. And just very quickly, only announced yesterday, please make sure you're all aware of the new childhood vaccination service that was announced last night for 2 to 3 year olds. It's a very, it's a pilot, only going to run for 1 season initially. And you're talking fairly small numbers of children that are eligible, but it's a good way of proving once again that community pharmacy is the place to go for your vaccination or for your, in children's cases, for your nasal spray. So please make the most of that. We're looking forward to some great success across Thames Valley. Thank you once again for attending this evening. And please make sure you subscribe to our YouTube channel, our podcast channel, our Signal group, and our weekly digest. There's lots of information out there for you. I know sometimes it can be a bit overwhelming, but we're here to help. So thank you once again for attending this evening, and we look forward to meeting you either face-to-face in future events or on our next webinar in the next couple of months or so. Thank you very much, everybody. Have a great evening. Thank you.